Now we are going to start with the cardiovascular system. The first chapter is vasodilators. As you know, vasodilators are going to decrease the BP. I told you vasoconstriction will increase the BP, so dilators will decrease the BP. Now we have three kinds of vasodilators because we have different vessels in the body. If it is dilating the arteries, they are known as arterial dilators. If it is dilating the veins, venous dilators. If it is dilating both of them, these are mixed dilators. So if you are causing arterial dilation, it will decrease the afterload. Easy to remember, A for A. If it is dilating the veins, it will decrease the preload. Now whenever this decreases preload, it causes a side effect that is known as postural hypotension. It causes something known as postural hypotension. Even mixed will decrease both preload and afterload because it is dilating both arteries and veins. So here also you will have the side effect of postural hypotension. Why? Because there is venous dilation. Now let us see what are the examples of arterial dilators. These are potassium channel openers, you can see here, calcium channel blockers and phenol-dopam. In autonomic nervous system we have already studied. Phenol-dopam is not so important for us in the autonomic nervous system, so we are going to start with the potassium channel openers and the calcium channel blockers. Now in the venous we have only nitrates that we need to study. In the mixed there are RAS inhibitors and sodium nitroprusside. Sodium nitroprusside, I will talk about it in the hypertension chapter. Why? Basically because it is decreasing the BP, so it can be used in the treatment of hypertension. Starting with the potassium channel openers, you can remember with the name of MDH. Yes, MDH, minoxidil diazoxide and hydralazine. Yes, minoxidil is used for hair loss. It is used topically for androgenetic alopecia. Side effect is going to be, what is the use first? I already told you, it is androgenetic alopecia. You are using it. It is a cutaneous vasodilator, so it will increase the blood supply and it will decrease the hair loss. Yes, it will decrease the hair thinning also. Now what would be the side effect? It will cause unwanted hair growth, that is hirsutism. Now coming to the diazoxide. This is drug of choice for a tumor known as insulinoma. Why? You need potassium channel blockade to release insulin. But if you are opening the potassium channels, what will happen? Insulin will not be released, so insulin release is decreased. That is why it is used in insulinoma. Yes, now coming to the hydralazine. Hydralazine can also be used for hypertension. I am going to talk about this in the hypertension chapter, but what is the side effect? I told you in the general pharmacology, it is going to cause drug-induced SLE. So what are the drugs that will cause drug-induced SLE? It is SHIP drugs. So H is for hydralazine, SHIP drugs, D is for dapsone. Yes, this happens in slow acetylators. I also told you the reason why. Now coming to the calcium channel blockers, we have two types of calcium channel blockers. These are DHPs and non-DHP. DHP means dihydropyridines and the other one is non-DHPs. Now DHPs are very easy. These are having dipins in their name. Yes, DHP dipins, rhyming, easy to remember. You can see here nifedipine, nicardipine, clebidipine, nimodipine, all of these. Now if you see nimodipine is cerebroselective. That means it works well in the cerebral vessels. So it can be used. It can be used in subarachnoid hemorrhage or intracranial hemorrhage whenever there is vasoconstriction that is causing ischemia. So to prevent this from happening, we can use something known as nimodipine. This is a very important MCQ. This is what I want you to remember. Now coming to the non-DHPs. Non-DHPs will also block SA node and AV node along with vasodilation. SA node and AV node is also blocked. So what might happen? It might decrease the heart rate or it might keep the heart rate normal. Why am I talking about this? See, dipines are vasodilators. When BP is decreased, there is reflex tachycardia. Okay, non-DHPs, when BP is decreased, there should be a reflex tachycardia as well, but since we are blocking SA node and AB node, it might keep the heart rate normal or decrease it. Yes. So, what I want you to remember, there are two drugs, verapamil and diltiazem. Since it is decreasing the heart rate, you should never give it with beta blockers. Yes, beta blockers will decrease the heart rate. If you are giving non-DHPs, it will also decrease the heart rate. It will cause a lot of bradycardia. So, that is not good for the person. That is why non-DHP and beta blockers are avoided together because of marked bradycardia, because there is a lot of bradycardia. This is what I want you to understand. Now, coming to the nitrates, these are venous dilators. So, it will cause postural hypotension because it decreases the preload. I have told all of this. Nitrates are having high first pass metabolism. I have told you in the absorption chapter, when there is high first pass metabolism, bioavailability decreases. That is why I told you seriously nitrates have large first pass metabolism. That is the mnemonic, remember. So, this is the reason why whenever a person is having anginal attack, you give nitrates sublingually. Yes, you will give it sublingually. So, when you give it sublingually, it will be directly absorbed into the systemic circulation without going through the liver. That is why we give it sublingually during an acute attack. Yes, but if you want to give it for prophylaxis, you will give it in oral doses, but at higher doses, because it is having high first pass metabolism. I want you to remember this. You can remember these drug names IDN, IMN, isosorbide dinitrate, isosorbide mononitrate. Yes, these drugs are used commonly. Now, coming to the side effects of this, what is important? The side effects are, it will cause headache, postural hypotension, I have already told you. And then there is something known as Monday's disease. This is what is seen in nitrate industry workers. It is what is seen in nitrate industry workers. Okay, this is very important, Monday's disease. Why? Because they are having continuous nitrate exposure from Monday to Friday. Yes. So, usually what happens, by the end of the week, these nitrates, the enzyme that are releasing the nitric oxide from the nitrates are utilized, and it will have nitrate tolerance. So, the person will not have any symptoms by the end of the week. But once they take a rest or a holiday on Saturday or Sunday, what will happen? These enzymes will start working again. Suddenly on Monday, this nitric oxide will be released and it will cause headache. This is what is known as nitrate. This is what you see in a nitrate industry workers. This is what is known as Monday's disease. So, I am saying that there is a nitrate tolerance as well. So, if you are giving a tablets in a person daily, it will cause nitrate tolerance. So, how can you prevent this? You at least have to keep 8 to 6 hour drug free period to prevent this. This is what you can see. Now, after the side effects, where is it contraindicated? See, nitrates are contraindicated with PDE5 inhibitors. This is very important. PDE5 inhibitors. What are these PDE5 inhibitors? I have already told you before, it is sildenafil and tadalafil. If you understand from the before, I told you nitrates will release nitric oxide. Now, what will nitric oxide do? It will activate the guanylyl cyclase, it will activate the cyclic AMP. This will cause the vasodilation. Now, if you give sildenafil, what will it do? It will block this PDE5, it will increase the cyclic AMP, and it will increase the vasodilation, and it will cause a lot of vasodilation. The person will go into shock. Which shock? Hypotensive shock. That is the reason why we should not use it together. These are very, very important MCQs that have been asked previously. Okay. Please remember, non-DHPs are contraindicated along with beta blockers. Nitrates are contraindicated along with PDE5 inhibitors. This is what I want you to remember, along with the nimodipine. Insulinoma, what is the drug of choice? This is diazoxide. Now, what is left out? Sodium nitroprusside. Yes, this is a mixed one. Now, it is used in hypertension, but the most important one that I want you to remember is sodium nitroprusside will cause a side effect of cyanide toxicity. It will cause cyanide toxicity. It is also photosensitive. That means if you give it in the light, this drug will be broken down. So what you do, you cover it with a dark papers or a dark cover and then you give the IV injection. That is what is sodium nitroprusside. Yes, in the forensic you must have studied the antidote for cyanide poisoning. This is hydroxycobalamin. If hydroxycobalamin is not there, you can give Lilly's antidote. What is Lilly's antidote? It is nitrites and sodium thiosulfate. Yes, please revise it from the forensic. Okay. Now, coming to the second chapter, this is antihypertensives. So, when a person is having hypertension, how will you treat this hypertension? You tell me. How will you treat this hypertension? First, for the treatment, you should ask him for lifestyle modifications. Diet, exercise for at least 3 months, and when then there is no improvement, then you will go for the drugs. Now, in the drugs, which drugs can be used for hypertension? We have ABCD drugs. Yes, A for ACE inhibitor or ARB, B for beta blocker, C for calcium channel blocker, D for diuretics. These are all the drugs that we have. Okay. Now, we are not using beta blockers anymore as a first line these days. So, beta blockers are out. These are not used as first line. They are used only if there are some indications that I will tell you in some time. Okay. Start always with 2 drugs. What can be these? They are telling you to start either with A plus C or A plus D. What do you mean by A plus C? A plus C means ACE inhibitors or ARB along with the calcium channel blocker. You will give a long acting oral calcium channel blocker, obviously, because it is for the treatment. No, so you will give amlodipine. That is what is being used in the practice, but the guidelines are saying benidipine is better. Now, coming to the diuretics, we use thiazide diuretic. So, in the textbook it is written chlorthalidone, but the guidelines are saying indapamide is better. They are saying that it has lesser side effects, lesser metabolic side effects. You know what are these metabolic side effects about the thiazides I am talking about? Hyperuricemia, hyperglycemia, dyslipidemia, all of them you see. Yes. Now, this is what are the drugs we are using, either A plus C or A plus D. Now, even after 6 months with 2 drugs, if this is not improving, we have to give all the 3 drugs together. Okay. Even after 6 months, if it is not reducing with these 3 drugs, then you will have a doubt. What is the problem? Is the person having secondary hypertension? Look for secondary hypertension. If not, then look for non-compliance. Non-compliance means the patient might not be taking any of these tablets, or he might be taking 1 or 2. Yes. If the patient is still compliant and if the BP is not reduced, if he doesn't have secondary hypertension, this is what is known as resistant hypertension. Now, what is the drug of choice for this resistant hypertension? This is going to be spironolactone. Drug of choice for resistant hypertension is spironolactone. If you remember, spironolactone is a potassium sparing diuretic. Yes, this is what we have studied. It is an aldosterone antagonist, so it will cause hyperkalemia. Now, coming to the drugs. Yes, ACE inhibitors. What is it ending with? All of them are prils. Captopril, lisinopril, enalapril. ARBs, these are sartans. Telmisartan, losartan, valsartan, and azilsartan and olmesartan. Yes, all of this will have a side effect of hyperkalemia. Why is it having hyperkalemia? Pretty easy to remember. I told you, see, ACE inhibitors, this will block renin angiotensin aldosterone system. So, if you are blocking this aldosterone, I told you it will cause hyperkalemia. That is why you see hyperkalemia in both of them. But in ACE inhibitors, you have an extra side effect like cough and angioedema. Because when you are blocking the ACE enzyme, bradykinin will increase, and this bradykinin will cause cough and angioedema. So, if you don't want this dry cough and angioedema, you are going to use ARBs. Did you understand this? Yes. Now, what are going to be the contraindications in these drugs? Okay, what are the contraindications? These are teratogenic drugs. So, can you use them in pregnancy? No, obviously. These are contraindicated in pregnancy. And also bilateral renal artery stenosis. you cannot use them. Bilateral renal artery stenosis, you can use them in unilateral renal artery stenosis but not in bilateral. It is contraindicated. So remember this. Contraindications are pregnancy and bilateral renal artery stenosis. Now, why am I not telling you the uses? Because all of the uses of the tablets are given in this one table. You remember this, you will know all the hypertension. Now, what is the best drug for hypertension with diabetes mellitus, nephropathy, stroke, retinopathy and scleroderma renal crisis? These are ACE inhibitors or ARBs. ACE inhibitors or ARB. Why it is nephroprotective? It is protective from the diabetes, it is protecting the retinopathy. So all of these conditions, these are target organ damages. What are you using? It is ACE inhibitor or ARB. Now, if a person has bilateral renal artery stenosis, I am telling you, you cannot use ACE inhibitor. So what will you use? You will see here. If a person has Raynaud's disease, bilateral renal artery stenosis, isolated systolic hypertension, the drug is going to be calcium channel blocker. Now, coming to the important one, if a person has stable angina, HCM, that is hypertrophic cardiomyopathy, hyperthyroidism and migraine, the drug of choice is going to be beta blocker. Now you tell me, what is the drug of choice for migraine prophylaxis? Migraine prophylaxis, yes, it is propranolol. It is propranolol. We have already studied this in autocoids. Yes. Now, if a person has hypertension with BPH, I already told you which blocker, alpha blockers. Which alpha blocker? Alpha 1 blocker. What is it? It is prazosin. It is prazosin. Let us suppose if a person doesn't have hypertension, then you give silodosin or tamsulosin. This is what we have studied. That is why I told you it also causes postural hypotension. Now, hypertension with hyperaldosteronism. Now, hyperaldosteronism means aldosterone levels are increased. So, you have to give an aldosterone antagonist. So, the answer is going to be spironolactone. Why? Spironolactone is also a diuretic. So, it will decrease the blood pressure, isn't it? Now, cheese reaction, all of you know, told you so many times, this is going to be IV phentolamine. Yes. Now, pheochromocytoma, I told you how long the name is, the drug name is almost similar. It is going to be phenoxybenzamine. It is going to be phenoxybenzamine. Next, coming to the osteoporosis, if you remember in the diuretics chapter, I told you thiazides will absorb the calcium, so it will cause hypercalcemia. Isn't it good for osteoporosis? It is decreasing the BP, increasing the calcium. So that is why thiazide diuretics are good for hypertension with osteoporosis. Now, if a person has hypertension with postmenopausal hot flushes, you can use clonidine. Yes. Now, we'll talk about emergencies. Yes. There is something known as hypertensive crisis. When do you have hypertensive crisis? When the BP is more than 180 by 120, that is what is hypertensive crisis. If there is no target organ damage associated with this, that is what is known as hypertensive emergency. There is no target organ damage. But if there is target organ damage, then we call it hypertensive emergency. Emergency means target organ damage is present. Urgency means there is no target organ damage. Now, what is the drug of choice here? Drug of choice for urgency is clonidipine or nifedipine, oral tablets you can give. But emergency, there is target organ damage. You have to give IV drugs like IV nicardipine. This is a calcium channel blocker. Yes, if this is not available, then you can use something known as IV nitroprusside. This is what I told you. This is a mixed dilator. It will cause cyanide toxicity. The antidote is hydroxycobalamin. So that is what IV nicardipine. If it is not available, IV nitroprusside. That is for hypertensive emergency. But what about hypertensive emergency in pregnancy? In pregnancy, you cannot use this drug. The best one is IV labetalol. If this is not available, then you can use hydralazine. This is why I told you I will talk about the hydralazine in the hypertension chapter. Yes, hydralazine can be used in the pregnancy. This is what I want you to remember. Hypertensive emergency, this table is pretty important. So you can remember in normal people, that means non-pregnant people, or you can write non-pregnant people. What are the drugs? It is nicardipine and nitroprusside. See, N for N. N for N. Nicardipine, nitroprusside, non-pregnant. For pregnant, it is labetalol, hydralazine, labetalol. LOL is there. It is a beta blocker. Okay. Now, what about hypertension in pregnancy? Normal hypertension. There is something known as chronic hypertension and pregnancy-induced hypertension. Chronic hypertension means female is already having hypertension and she became pregnant. Pregnancy-induced hypertension means pregnancy has caused the hypertension. Now, in chronic hypertension, you can use drugs like alpha-methyldopa, labetalol and nifedipine. In pregnancy-induced hypertension, again you can use labetalol, hydralazine and nifedipine. Yes, pretty simple. If you remember labetalol, you can understand that labetalol can be used everywhere in the pregnancy. Yes. Now, coming to the third chapter, that is heart failure. We have two kinds of heart failure. One is HFrEF, the other one is HFpEF. HFrEF means reduced ejection fraction, PEF means preserved ejection fraction. Now, according to the ACC-AHA guidelines of heart failure, we have a pretty good treatment for HFrEF. So, we are going to discuss the treatment of HFrEF. Okay. So, everything is here is about HFrEF. HFrEF means ejection fraction is reduced. So, let us suppose if there is a damage to heart, its ejection fraction is reduced, what will happen? The heart will feel bad obviously, and it is going to tell the brain to do something. Yes, what will the brain do? Brain will listen to our heart and it will activate the sympathetic nervous system. Sympathetic nervous system, this much you already know, we talked about it in the sympathetic nervous system. It is fight or flight response. What is released? Norepinephrine. So, norepinephrine is going to be released and it will act on all the receptors like alpha and beta. Now, if it is acting on the alpha receptor on the blood vessel, it will cause vasoconstriction. It will cause vasoconstriction. Now, if this norepinephrine is acting on the beta 1 receptor of the heart, beta 1 receptor of the heart, it will increase the heart rate, it will increase the contraction. See, our contraction is decreased. In EF is decreased means contraction is decreased. That is why our body is trying to compensate it by increasing the contraction. Good thing, no? Good thing. Yes. So, this is one good thing. Okay. But what has happened? There is vasoconstriction and increased heart rate as well. This will further worsen the heart failure. So, let us suppose a person is having EF of 40 and our person heart is trying to make this EF into 60. So, in this process, it is activating the sympathetic nervous system. But this sympathetic nervous system is causing further damage instead of repairing it, and from 40 it will fall to 38, from 38 it will fall to 35. So, this is how HFrEF is going to happen. It is a cyclical process that our body is doing. So, we have to break this cycle. Did you understand? Now, beta 1 receptor is also present in the kidney. If this is activated, it will activate renin-angiotensin-aldosterone system. Renin-angiotensin-aldosterone system. Now, when all of this is happening, you don't want all of this to happen. So, you have to give these drugs to stop the compensatory mechanisms that is happening by the body. First, for vasodilators, you will give for vasoconstriction, you will give vasodilators. Example is nitrates. But you don't use it for prophylaxis, you use it in acute episodes or acute attacks. So, if a person has symptoms, then you use nitrates. But if the person is not having symptoms, if you want to stop the progression of HFrEF, you cannot cure HFrEF, you can only stop the progression. How can you stop it? See, this is happening because of beta receptor. So, the first drug you are going to give is a beta blocker. So, the first drug you are going to give is a beta blocker. Then, vasoconstriction can also be blocked. Vasoconstriction can also be blocked, and renin-angiotensin-aldosterone system can also be blocked by ACE inhibitors. Now, we have a new drug that is better than ACE inhibitors, that is ARNI. ARNI means angiotensin receptor blocker plus neprilysin inhibitor. Neprilysin inhibitor. Okay. To stop this aldosterone, we will give aldosterone antagonist, that is spironolactone. That is spironolactone. Now, we have seen one drug in diabetes mellitus that is also useful in heart failure. So many questions have been asked on this drug, so many times. That is SGLT2 inhibitors. Why? It has got good mortality benefit in HFrEF. SGLT2 inhibitors are gliflozins, dapagliflozin, empagliflozin, all these gliflozins. So all of these are the first line drugs that you use in the prophylaxis. Yes, for chronic HFrEF. So what are the drugs? Beta blockers, ACE inhibitors or ARNIs, aldosterone antagonist or SGLT2 inhibitor. So what do you say? See, when EF is reduced, our sympathetic nervous system is overacting. Yes, it is overacting and damaging the body. So we tell our sympathetic nervous system to stop. बस काम करना बंद कर दो. Yes, बस stop. So that is the mnemonic here. Beta blocker, ARNI, aldosterone antagonist, SGLT2 inhibitors. So these are the first line drugs. So these have very good mortality benefit. That is why these are first line drugs. So they will ask you which drugs will decrease the mortality or which drugs have very good mortality benefits. These four drugs will reduce the mortality. That is why these are the first line drugs. Now first we'll see the first line drugs. Beta blockers are, we use 3 beta blockers, MBC, metoprolol, bisoprolol or carvedilol. We can start with any of them. Usually we start with carvedilol. Now ACE inhibitors or ARB, which is better? ACE inhibitor is better, but ARNI is even better than ACE inhibitor in heart failure. Okay, ARNI is even better, but best is ARNI. What is ARNI? It is valsartan plus sacubitril. Why we are giving ARB plus neprilysin inhibitor? Because neprilysin inhibitor will also cause angioedema. If you give it along with ACE inhibitor, it will also cause angioedema. So there is severe angioedema. So that is why these are contraindicated together. They cannot be given together. Before we made a drug called omapatrilat. It is ACE inhibitor plus neprilysin inhibitor. It has caused severe angioedema in patients, so this has been banned. Now aldosterone antagonist, I already told you, spironolactone, finerenone. Spironolactone will have gynecomastia and menstrual abnormalities. That is why we will prefer finerenone. SGLT2 inhibitors, canagliflozin, empagliflozin, dapagliflozin. So what are the drugs that are decreasing the mortality? Drugs decreasing the mortality. I already told you that mnemonic, bus. All these drugs will decrease the mortality. So these have very good mortality benefit. Okay. Now there are other drugs which will decrease the mortality in some patients, but not up to this level, but in some patients it does. What are those drugs? These are ivabradine. Okay. Versigouat. If you know riociguat, versigouat is also somewhat similar to that. Yes. Now last one is, so if you remember riociguat, versigouat is also similar to riociguat. It is a guanylyl cyclase stimulator. Okay. Now last is hydralazine plus nitrate, isosorbide dinitrate. So these three drugs will also decrease mortality to some extent. Usually what they will ask in the exam is which drug does not decrease mortality or does not have mortality benefit, that is digoxin. Digoxin has no mortality benefit. Please remember, more than enough. If you cannot remember all this, at least remember digoxin has no mortality benefit. So this is about chronic HFrEF. Now from the chronic case, if suddenly something worsens, it will cause acute heart failure. That is what is known as acute decompensated heart failure. Now there are 4 classes in this. For you, the last 2 are important. One is pulmonary edema. Pulmonary edema you studied so many times in the medicine. Yes, bat wing appearance that you see, frothy sputum, pink sputum, all of these are happening. Now what is the treatment in pulmonary edema? You will give IV furosemide. This is what I want you to remember. You give IV diuretics, that is IV furosemide. Now coming to cardiogenic shock. Now what is cardiogenic shock? See, when there is acute decompensated heart failure, it is also known as acute congestive heart failure. Yes, acute congestive heart failure. What is the drug of choice? Drug of choice is dobutamine. Dobutamine is a beta 1 agonist. I already told you this in the SNS chapter if you remember. If dobutamine cannot be used, what do I mean by dobutamine cannot be used? If a person is on beta blocker, a person is having chronic heart failure, then he is having acute heart failure. That means he is already taking beta blocker. No. Then if you give dobutamine, will it work? It will not work. Why? Because this beta blocker is blocking this beta 1 receptor. Did you understand? We are giving a selective beta blockers mostly, so it is blocking this beta 1 receptor. So what can we do? We can use a drug called milrinone. Milrinone. It is a inodilator. That means it will cause inotropy as well as vasodilation. By simple way to say that beta 1 receptor is a GS receptor. We've already studied beta 1 is a GS receptor. So GS receptor, how does it work? It will work by increasing the cyclic AMP. This cyclic AMP is what is causing vasodilation. Why? Because it is smooth muscle relaxation. I told you GS will stimulate everything except smooth muscle. So it is causing vasodilation, and it will also increase the cardiac contraction. So basically this is inotropy, this is dilation. Now if you give milrinone, milrinone is a PDE3 blocker. What will PDE3 do? Cyclic AMP is metabolized by PDE3. Now if you block this PDE3 by giving milrinone, this cyclic AMP will increase. When the cyclic AMP increases, cardiac contraction will increase, vasodilation will increase. So what will happen? Inodilation. That is why we call it inodilator. Did you understand this much? Acute congestive heart failure, dobutamine. If this does not work, we will give milrinone. Now we have a new drug called levosimendan, but we are not using it. We are now using milrinone. Now if a person has acute congestive heart failure along with decreased BP or hypotension, that is what is known as cardiogenic shock. And in cardiogenic shock you can use norepinephrine. It is norepinephrine. I told you norepinephrine is a potent vasoconstrictor, so it is drug of choice in almost all these shocks except for anaphylactic. Yes, anaphylactic shock we use epinephrine. This is what we studied in the beginning of ANS. That is why I told you ANS comes everywhere. It is the most important chapter. So we are done with this heart failure. Yes. Now coming to the fourth chapter in this, it is about the anti-anginal drugs. Now all of you know it is angina. Angina is because the chest pain, there is decreased oxygen supply to the myocardial muscles. Yes, you know. So there is increased demand and decrease supply. So what you should do in angina, you either have to increase the supply or decrease the demand. Demand is because of heart rate. Yes. So you can decrease the heart rate. You can decrease the heart rate by giving beta blocker. Yes. Or you can increase the supply of the blood by giving nitrates. So these two drugs we use it in all coronary artery diseases. Now coronary artery diseases we have two kinds. One is chronic stable angina and the other one is ACS. ACS means acute coronary syndrome, as you know. In ACS, the troponin I is elevated. When troponin I is elevated, it tells you that it is infraction. It is not ischemia anymore, it is infraction. So basically what I am telling you, please try to remember this. Coronary artery disease, I am saying we have angina, that is chronic stable angina, as well as ACS. So first, starting with the chronic stable angina, I told you have to use nitrates, beta blockers, and since it is a coronary artery disease, it is happening in the arteries, there is plaque formed with platelet. So you have to give an antiplatelet drug, that is aspirin. Now there are pleiotropic effects of statins, that is the reason why statin should also be used in coronary artery disease. So these are the four drugs that you use almost everywhere. What do I mean by this? See, this is the treatment of chronic stable angina. Now if a person is having acute coronary syndrome, in this there are again divided into two, NSTEMI and STEMI. Now in the ECG, if there is ST elevation, we call it STEMI. If there is ST depression, we call it NSTEMI. So coming to NSTEMI, what are the drugs that we are using here? If you see, Nitrates, beta blockers, statin and aspirin. Again, I told you these are going to be same everywhere, but in ACS you have to give dual antiplatelet therapy. So you have to add one more antiplatelet, that is clopidogrel. Now what you have to do in NSTEMI, you have to give an anticoagulant as well. Anticoagulant, it could be heparin, or the patient might need PCI. So it is plus or minus, might need PCI. You will do after 24 hours. Okay, it depends on the condition. Now coming to the STEMI. STEMI means rupture of the plaque and then there is fibrin clot formation. So again, when there is STEMI, you have to give all of these drugs: nitrates, beta blocker, statin, aspirin, clopidogrel. But since there is clot that is blocking the entire artery that is made up of fibrin, you can either do PCI. It is to be done within 90 minutes. If PCI is not available, then you go for thrombolysis. How do you do it? With the help of streptokinase. That's all. Did you understand? Angina is nothing but increased demand, decreased supply. Now, how can you do this? How can you reverse this? You give a beta blocker, you give a nitrate, and you also give an antiplatelet drug, you also give a statin. This is going to be same in almost everywhere. In STEMI, you are going to add a dual antiplatelet along with anticoagulant. STEMI, again dual antiplatelet along with thrombolysis or PCI. PCI is preferred. If it is not available, you are going to do thrombolysis. Now, there are some other anti-anginal drugs that we are going to see. They have been asked in the exams about their mechanism of actions. It is going to be easy because everything is in their name. Everything. Let me tell you how. See here, the first drug is ivabradine. Now, it acts on IF channel. This is funny current channel. Now, you see here VA. The side effects are visual abnormalities like luminous phenomena, you can see here, and phosphines. Now, if you see here BRAD, it is also causing bradycardia. You see here, it is also causing bradycardia because it is blocking the IF current on the SA node. That's all. It also blocks the IF channels on the eye. That is why it causes these side effects of visual phenomena. Yes, luminous phenomena and phosphines. Now, coming to the ranolazine. Now, how is this working? Again, it is given here. It is blocking the late inward sodium channels. La means late, In means inward, again N means sodium channels, Na channels. So, late inward sodium channel blocker. Now, next is nicorandil. CO, instead of C, you remember it as K. KO is potassium channel opener. It is potassium channel opener. Now, trimetazidine. How can you remember this? Trimetazidine. Yes, see here carefully. IN means inhibiting. It inhibits the metabolism of triglyceride by blocking PFOX. See, heart usually uses fatty acids for their metabolism when the entire organs use glucose, but our heart is using fatty acid. So what will this trimetazidine do? It will convert the fatty acids dependence to glucose. So heart will start using glucose as its fuel instead of fatty acids. Why? Because fatty acid oxidation requires a lot of ATP. It is energy consuming process. So when we turn it into glucose, our ATP is saved and we are helping the heart. That is why trimetazidine is helpful in the chronic stable angina as well, because it is decreasing the demand. Now, next is Prince metal angina. This is also known as variant angina. This is also known as vasospastic angina. This is happening because of vasospasm. Yes, so because of vasospasm it is happening. How can you treat it? During the acute attack, you have to give nitrates. But for prophylaxis, for long-term prophylaxis, the drug of choice is calcium channel blocker. That's all about the anginal drugs that you see even in medicine as well. Okay. Now coming to anti-arrhythmic drugs. Now, Listen carefully, I will tell you one or two mnemonics. With the help of this, you will be able to understand the entire arrhythmics chapter, even from the medicine as well. You will be able to solve all the questions from pharma and medicine. Please listen carefully for the next 15-20 minutes. Yes. Now, see here, how does an action potential work? How does an action potential take place? If you see here, action potential, how does it work? First, there is depolarization, then there is repolarization. Yes. How does depolarization happen? With the help of sodium going inwards. This is what you studied in physiology. How does repolarization happen? With potassium coming outwards. This is what is happening. Simple. If sodium, that means positive charge, is going inside, it is causing depolarization. Now depolarization is relaxation. So potassium, that is a positive charge, from inside the cell is going outwards. That's all. So that is depolarization, repolarization. Now if you take an example of a myocardial cell, let us suppose this is a myocardial cell in the ventricle. How does the action potential takes place? Let us see. Obviously, I told you this is depolarization, sodium will go inside. Okay, then what should happen? There should be repolarization. So potassium is coming outside. Perfect, amazing. But in the heart, once the potassium starts coming outside, unfortunately the calcium is going inside. You see here, calcium is going inside, that is a positive charge, but potassium is coming outwards, that is a positive charge. So positive, positive, it cancels out. What will happen? It will remain as a plateau. It will remain as a plateau. It is not changing. Now, after a point of time, these calcium channels will close. Once these calcium channels will close, obviously the same thing is going to happen. The potassium comes out as usual. That is the reason why in the myocardial cells, during repolarization, there is a plateau. This is what is happening. When does depolarization happen? During contraction. When does repolarization happen? During relaxation. This is a ventricular cell. So what is this? When is the systole or contraction starting? Q. When is it ending? The relaxation is ending at T. So this is what is known as QT segment. Will you accept? This is what is known as QT segment on ECG. This is how you can correlate. This is how you can correlate. Now what happens in arrhythmia? What happens in arrhythmia? In arrhythmia, the heart rate is increased. If the heart rate is increased, what will happen to these QTs? They will become smaller like this. Yes, they will become smaller like this. Now, what should be the treatment of arrhythmia? What should be the treatment of arrhythmia? Obviously, you have to increase this QT, no, you have to increase this action potential. How can you do it? You can either block sodium channel. If you are blocking sodium channel, what will happen? It will become like this. Or you can block potassium. If you block potassium, what will happen? See, it will stretch out like this. Okay. You can either block sodium or you can either block potassium. If you block sodium, this will happen. If you block potassium, this will happen. Did you understand? Now, so is it safe to say some block sodium channels, some block potassium channels? Now, which one would you like to block? If it is me, I would like to block potassium channels because potassium is working for a longer period of time. So I can say some block sodium channels, some block potassium channels. But I would prefer potassium channels. That is why I am going with the mnemonic. Some block potassium channels in arrhythmia. That's all. Now, drugs are magnesium sulfate. Now, why am I saying like this? We'll see. Some block potassium channels in arrhythmia, drugs are magnesium sulfate. Remember this. Now, some. S for sodium. First is sodium channel blocker. Next is beta blocker. Next is potassium channel blocker. Next is calcium channel blocker. These four are the first four classes of drugs. Did you understand? This is what is von William classification. Von Williamson classification in the anti-arrhythmics. What are they? Von Williams classification. It is class 1, class 2, class 3, class 4. I already told you. Some block potassium channels. So first is sodium channel blockers. The second one is beta blockers. Third one, what is it? It is class 3 potassium channel blockers. Class 4 is calcium channel blockers. That's all, done with the mnemonic. Now, What are the other drugs? What are the other drugs in arrhythmia? A for adenosine, D for digoxin, another A for atropine, magnesium sulfate for magnesium sulfate. That's all. These are the other drugs. These are the other drugs. So all the drugs in arrhythmia are done. That's all. Class 1, class 2, class 3, class 4 done, and these are the other drugs. You are done with all the anti-arrhythmic drugs. Now you just have to remember the uses. Now class 1, if you see the class 1 is unfortunately again divided into 3. Unfortunately divided into 3. If you have attended my class, I usually tell you a story about how a girl, buys fleece. So I remember it with the help of a mnemonic. For people who have attended my class, you know this. Queen likes fleece. This is what I tell in the class. Queen likes fleece. So Q is for quinidine, likes is for lignocaine, fleece is for flecainide. These are 1A, 1B, 1C. These are 1A, 1B, 1C. All of them will block what? Sodium channels. Now, how did the queen buy the fleece? She bought the fleece in a box. So I remember it like this: box. What is this box? See, B means it also blocks potassium channel. O means it opens potassium channel. X means no effect on potassium channel. Why am I saying all of this? Why do I have to remember all of this? See, if it blocks potassium channel, what will happen? There will be a QT prolongation. Because potassium is almost everywhere in the repolarization. It will cause QT prolongation. Yes. So 1A drugs will itself cause QT prolongation. If you cannot remember box, just remember Q for Q. Quinidine will cause QT prolongation. Yes, quinidine will cause QT prolongation. I told you potassium channel blockers will cause QT prolongation. So this will also cause QT prolongation. That's all. These are the most important MCQs that are being asked. Third class drugs. What are they? Potassium channel blockers. Now 1A drugs. What are they? Quinidine and procanamide. They will also cause QT prolongation. This is very, very, very important. Why? QT prolongation can cause a torsade de pointes. Yes. So that's all about the first class. Second class are all beta blockers. Third class is potassium channel blockers. That is amiodarone. Now amiodarone is a potassium channel blocker. True. It is also blocking the sodium channels. True. It is also a calcium channel blocker. True. It has some beta blocking activity also. Yes, some. Now, so it is a wide spectrum drug. So amiodarone can be used almost everywhere. What is important about this? Its side effects. Will have thyroid abnormalities, and most importantly, it will cause ILD or pulmonary fibrosis. Now this is about the class 3. You also have ibutylide and other drugs, but important is amiodarone. Now what is important is sotalol. It is a beta blocker, but it is a class 3. Beta blockers are class 2, but sotalol is class 3. Please remember this. Class 4 is calcium channel blocker. DHP or non-DHP? Tell me, which is decreasing the heart rate? Obviously, DHP or non-DHP? It is non-DHP. So, verapamil and diltiazem. That's all these classes of drugs. Now, if you understood this much, now I'll tell you how to solve any questions in the arrhythmias. Yes, see here carefully. Let us suppose a person is having arrhythmia and his BP is stable. That means BP is normal. If the BP is normal, we call him hemodynamically stable patient. True. So you see here this arrhythmias. In a hemodynamically stable patient, let us suppose the examiner will ask you two things. It could be either an atrial tachycardia, that means a supraventricular tachycardia, or the examiner might ask you about the ventricular tachycardia. So supraventricular or ventricular. Now in the supraventricular tachycardia, I am dividing it into two classes which examiner usually asks. That is PSVT. PSVT means a paroxysmal supraventricular tachycardia. Now PSVT again it has two types, AVRT and AVNR. Okay, this is one class. The other one is atrial fibrillation or atrial flutter. So SVT I have divided into two groups. Remember this: PSVT, atrial fibrillation or atrial flutter. Now how is PSVT happening? It is because of AV node re-entrant tachycardia. So in layman terms, if you take this is the AV node, this is the SA node. Yes, in the AV node the impulses will keep on rotating. Yes, if it keeps on rotating, the impulse will go again and again, again and again. Yes, so this will cause increased heart rate. That is what is known as arrhythmia, since it is originating from the above the ventricles. This is what is known as paroxysmal supraventricular tachycardia. Now, the pathology is at AV node. If you block this AV node, you will terminate the arrhythmia. Yes or no? So, what is the treatment here? AV node blockers. It is AV node block. Yes. Now, which AV node blockers can you use? I am telling you, the best AV node blockers are A, B and C. A, B and C. A for adenosine, B for beta blocker, C for calcium channel blocker. And this is what we have taught. Yes, beta blocker will also block AV node. Calcium channel blockers like verapamil and lentiazem will also block AV node. Adenosine will also block AV node. So that's all. So if you see carefully, adenosine is only available in IV. It works only for 6 minutes. It works only for 6 minutes. Yes, that is why you give it in a rapid flush. Now listen to me carefully. If you give any of these AV node blockers, this will terminate the arrhythmia. Termination of arrhythmia is known as rhythm control. That's why these are used in rhythm control. So that is why you see in your questions PSVT. If a person is hemodynamically stable, what is the first drug that you would use? It is IV adenosine 6 mg. It is IV adenosine 6 mg. Did you understand? Now, if a person is having acute PSVT, we will use adenosine. That is good because it is IV. Let us suppose a person is having had PSVT and now you want to prevent the further attacks of PSVT. For long-term management or prophylaxis, which one would you use? You cannot keep on giving injections. Yes. Now, so you would use beta blocker. This is 6 mg, not 6 minutes. It will work less than 6 minutes. It is the shortest acting drug. This is the shortest acting drug. The dose is 6 mg. Okay. Now, for prophylaxis, you would use beta blocker. Did you understand? Acute attack, adenosine. Prophylaxis, beta blocker. Now, let us suppose, they are telling you that a person is having PSVT and he has a history of bronchial asthma. Now, in bronchial asthma, you cannot use adenosine and beta blocker as well. So, in bronchial asthma patient, you will use calcium channel blocker. I hope you got it. That's all about PSVT. PSVT, you covered all the questions from AIIMS, NEET-PG and also the FMGE. This is what they are going to ask. Vagal maneuvers and all can be done before the pharmacological stuff, but after vagal maneuvers, ice packing, this doesn't work most of the times. When you come to pharmacology, you have to use the AV node blockers. AV node blockers are adenosine, beta blocker, calcium channel blocker. Adenosine for the acute attack, A. For prophylaxis, beta blocker. If a person has bronchial asthma, you cannot use both of them, you will use calcium channel blocker. Yes, this is PSVT. Please remember this. Now, coming to the atrial fibrillation and atrial flutter. Why is AFib or A-flutter happening? See, this thing is because of AV nodal reentrant tachycardia. But what about AFib and A-flutter? There is a ectopic focus. Depends on AFib or A-flutter, there is a ectopic focus. What will this ectopic focus do? It will give you lot of impulses. So many impulses. See, PSVT, it is somewhere around 200 or whatever it is, but this one will give you so many impulses. When these impulses has to go through AV node again, let us suppose if these impulses go through AV node, the rate of ventricles will increase. If their rate of ventricles are increasing too much, ventricle will start pumping like this. If it is pumping like this, the blood will not go into aorta. If the blood is not going into aorta, yes, the person will become hemodynamically unstable, person might go into syncope, person might even die. So that is why you don't want the rate of ventricles to increase. So you don't want these impulses to pass through AV node. So here also you are blocking the AV node. If you block the AV node, are you terminating the arrhythmia? No, you are not terminating the arrhythmia. You are only blocking the rate of ventricles. That is why this is known as rate control. Please understand carefully. Here AV node blockers are used for rate control, not rhythm control, not rhythm control. Rate control AV node blockers in AFib and atrial flutter. AV node blockers are used for rhythm control in PSVT. So if you are giving AV node blockers, you can control the rate. In AFib and aflutter, adenosine unfortunately doesn't work properly because it is a short drug. So here in AFib and atrial flutter, we will use the drugs called BCD. We will use the drugs called BCD. B is beta blocker, C is calcium channel blocker, D is digoxin. Did you understand? Beta blocker, calcium channel blocker and digoxin. Now, if you see here carefully, you might have seen in the questions, atrial fibrillation question, they will ask you which drug can be used to control the rate. That is beta blocker. Always, always, always beta blocker. Now, if a person has bronchial asthma, you cannot use beta blocker, so you will use calcium channel blocker. Now, let us suppose a person has HFrEF, means heart failure. You cannot even use calcium channel blocker. Why? If you use calcium channel blocker, it will reduce the contraction. So it cannot be used in HFrEF. Then you will use the last drug, that is digoxin. Did you understand? That is why in medicine you would have studied the only indication for digoxin is HFrEF plus AFib. This is the reason you have studied. So digoxin is used in HFrEF plus AFib. In bronchial asthma, calcium channel blocker. Beta blocker is the drug of choice. So this is what I want you to understand. To control the rate, BCD drugs in AFib and atrial flutter. But what about rhythm control? To terminate the arrhythmia, you have to stop the action potentials in the foci. You will do it with the help of amiodarone. Now, if you go to ventricular tachycardia, it could be VTach, it could be VFib, anything, the rhythm control is always done by amiodarone. But only exception is in digoxin induced ventricular tachycardia, you will use lignocaine. You will use what? Lignocaine. That's all. That's all you have to remember. If you know this much, you will solve all the questions. So patient is hemodynamically stable. If he is having PSVT, you will use ABC. If he has AFib or atrial flutter, BCD. If they are asking rhythm control, amiodarone. If they are asking rhythm control in VTach, it is amiodarone. VFib, amiodarone. But if they are asking digoxin induced arrhythmia, it is lignocaine. If it is hemodynamically unstable patient, then you will go for DC cardioversion, that is what? Shock. It does not matter what kind of arrhythmia he has. If he is having hemodynamically unstable, then you should always go for the DC cardioversion. That's all about this entire arrhythmia. Okay, if you understood this, you will answer all the questions about arrhythmias. So we will see here, atrial tachycardia, PSVT, which control? Rhythm control. What are the drugs? AV node blockers. What are they? ABC. AFib, rate control. AV node blockers. What are they? BCD, rhythm control. Amiodarone. Ventricular tachycardia, again amiodarone. Okay. Now if you see here, purple man syndrome. Yes, purple man syndrome or blue man syndrome, I would call it. Purple or blue. Yes, I would prefer blue. Blue man syndrome is caused by amiodarone. Yes, purple toe syndrome is caused by warfarin. Purple glove syndrome is caused by phenytoin. Okay, these are the important things about the colors. Now, coming to WPW syndrome, it is an accessory pathway. So, the best treatment of choice is to ablate this accessory pathway. So, treatment of choice is radiofrequency ablation. This much you already know. Now, coming to the acute episode, you can use procainamide or flecainide. Prophylaxis only flecainide. Yes. Now, torsade D pointers, you will use magnesium sulfate. We have finished almost all the drugs. Atropine we have studied in the first itself. I told you 5 drugs of choices. Atropine is drug of choice in bradycardia. Atropine is drug of choice in AV nodal block, OP poisoning, carbamate poisoning, early mushroom poisoning. That much you already know about atropine. Now, if it is a digoxin induced arrhythmia, you will use lignocaine. With digoxin, what are the things that you have to remember? Digoxin, what is the Antidote, it is digibind. It is what? Digibind. What is the mechanism of action of digoxin? It is an inotropic drug. It is inotropic drug. It will also cause side effects like gynecomastia. It will also cause side effects like gynecomastia and xanthopsia. Yellow greenish vision. It is xanthopsia. Now, what is important? What is important? If you see N, it produces a specific arrhythmia, that is what is known as non-paroxysmal atrial tachycardia with AV node block. This is a specific arrhythmia that is seen by digoxin. This is what I want you to remember about the digoxin. Now, coming to the last part, pretty simple, all of you know this. I am just going to rush through it. It is anti-dyslipidemics. If you want to decrease LDL, we have all these drugs. If you want to decrease triglycerides, we have fibrates. If you want to decrease lipoprotein here, we have niacin. Now, first start with the LDL. What is the drug of choice to decrease the LDL? It is statin. How do they act? By blocking the HMGA-CoA reductase. This is the rate limiting step in the cholesterol. Yes. So, HMGA-CoA reductase, but it is contraindicated in children and pregnancy. So, in children and pregnancy, what are the drugs that you can use? These are bile acid racines. These are drug of choice in children and pregnancy. You have to remember this. Now, these questions have been asked in NEET. Not all of them. The most important question that they have asked is NPC1L1, Niemann-Pick-like receptor is blocked by ezetimibe. PCSK9 is blocked by evolocumab and alirocumab. Yes. PCSK9 synthesis is blocked by inclisiran. This is what I want you to remember. That's all. Now, coming to fibrates, the side effects is myopathy and it can cause toxicity. It can cause toxicity with clarithromycin. I already told you. Clarithromycin. It can cause toxicity with clarithromycin. What is it? It is statin, not fibrate, it is statin. Statins will cause toxicity with clarithromycin and this will also cause myopathy. Statin myopathy is seen with clarithromycin. We have studied in enzyme inhibitors because statins are also metabolized by CYP3A4. Okay, good. Now, niacin, it decreases the lipoprotein A and niacin will also induce flushing. Now, in this flushing, in the olden days, we used to use aspirin. Now, we have a specific drug that is known as lorapiprant. So, that's all about the entire cardiovascular system. We'll do the questions, we'll understand about these arrhythmias, about how to use in PSVT and how to use in the atrial fibrillation. Then, you will understand the entire topics. Yes. As I've told before, here are some of the questions to see how much you have really understood the concepts. So, the first question that we're going to see here is, a 28-year-old man has been diagnosed with bronchial asthma. Obviously, then he would be started on inhaled corticosteroids to decrease the inflammation. During the follow-up, he mentions that he has observed another patient on similar treatment developed a white patch on his tongue. Now, other patient has developed a white patch on the tongue. Why? See, inhaled corticosteroids, these will reduce the immunity in the oral cavity, so it can cause fungal infection. So, it has caused oral candidiasis. Yes. Now, the patient is asking, how can you prevent this? Yes. Now, here are the options. Pressurized meter dose inhaler and nebulizer, spacer or dry powder inhaler. What will you do? Yes. Obviously, I have already told you, you have to use a device called a spacer. Now, coming to the 14th question, this is really important. Listen to me carefully. A 25-year-old woman on OCPs presents with a persistent cough for the past 4 weeks associated with low-grade fevers, night sweats, anorexia and unintentional weight loss. She also reports occasional streaks of blood in her sputum. On examination, she appears thin and pale. Okay. On chest auscultation, there are coarse crepitations in the upper lung zone. She started on ATT. Why? Because night sweats, fever, all of these are presumptive TB case. Yes, so she has been started on ATT. Now, what is the ATT? It is HRZE. 2 months of HRZE followed by 4 months of HRA. So, after she started on ATT, after sputum analysis and other investigations confirmed the diagnosis. Okay. A few months later, despite the regular use of her OCPs, she is found to be pregnant. Why? It is because of interactions. That much you already know. Now in general pharma, I already told you that R, rifampicin. Rifampicin is an enzyme inducer. Rifampicin is an enzyme inducer. So if it is an enzyme inducer, it will increase the CYP enzyme activity. Yes, and it will increase the metabolism of OCP. And when the metabolism of OCPs are increased, the effect will decrease. Did you understand? So it is causing OCP failure. That is what I told you. Rifampicin will cause OCP failure. Now it will be pretty simple. You don't even have to look at the options. Rifampicin induces hepatic microsomal enzymes causing OCP failure. Now coming to the 15th question. A 15-year-old man with a history of chronic stable angina. He presents to the cardiology clinic for a routine follow-up. His past medical history includes hypertension and hyperlipidemia. He has no history of myocardial infarction. He is on medications like aspirin, oral isosorbide mononitrate, that means nitrates, metoprolol and atorvastatin. The patient has recently developed erectile dysfunction. So without informing his physician, he has obtained sildenafil. Now, what is the most potential adverse effect that can be closely monitored in this patient? What can be seen in all of this? Now, is it increased frequency of angina episodes? No, it will not increase the frequency of angina episodes. Is it development of persistent priapism? Is it increased risk of gastrointestinal upset? Significant and potentially dangerous drop in blood pressure. Now, if you remember, nitrates, what will it do? It will increase the cyclic GMP. Yes, this will cause vasodilation. Now, this is metabolized by phosphodiesterase. Sildenafil is a phosphodiesterase blocker. If you block the metabolism, this will increase. If this increases, vasodilation will also increase. If vasodilation increases, what will happen? It will cause potentially dangerous drop in blood pressure, that is hypotension. So this is the side effect that you have to monitor. Got it? Now coming to the 16th question. A 45-year-old woman with a 5-year history of HFrEF presents to the cardiology outpatient department. Her current medications include valsartan sacubitril, that is an ARNI, carvedilol, beta blocker, spironolactone, aldosterone antagonist, vitamin D and dapagliflozin. It is SGLT2 inhibitor. Now, she presents with complaints of burning micturition, vaginal discharge with pruritus, fever, myalgia and lower abdominal discomfort. The urine examination was done and the culture and sensitivity reveals E. coli, that is more than 10 to the power of 5. Yes, 10 to the power of 5. Now, it is consistent with UTI. Which drug will cause UTI? This much you already know. Is it ARNI, beta blocker, SGLT2 inhibitor or spironolactone? Yes, everybody should be able to answer this. This is a PYQ. It is SGLT2 inhibitor. I've already told you. If you block a sodium glucose transporter, what will happen? Sodium and the glucose, both of them are lost in urine. So because of presence of glucose in urine, it can cause UTI. Now in the arrhythmia chapters, if you remember the slide I gave you about the arrhythmias, I told you I'll give you one question on which you'll be able to understand the arrhythmia. Now let us see. That is what is here. A 58-year-old woman presents to outpatient clinic with palpitations, fatigue and shortness of breath on exertion. Okay. She also repeats dizziness and occasional mild chest discomfort. Okay. She has a history of asthma with recurrent episodes of wheezing and she is currently on inhaled corticosteroid therapy and bronchodilator therapy. She was diagnosed with HFrEF, heart failure with reduced ejection fraction, HFrEF, asthma. Okay. HFrEF, she was diagnosed 3 years ago and is on medical management. She is currently using ivabradine instead of beta blocker because beta blockers will worsen her asthma, obviously. Now, on examination, pulse is more than 100, BP is 130 by 80, ECG is taken and it is shown below. Now, if you look at the ECG, these are all RR intervals. You see, are they regular? Are they regular? No, they are irregular. Are they regularly regular or irregularly irregular? Regularly irregular or irregularly irregular? You see here, there is no correlation between any RR interval, so it is irregularly irregular. That's what is there. So irregular RR intervals is known as atrial fibrillation. So the patient is having atrial fibrillation. Which of the following drug is the most appropriate first line choice for rate control? Rate control, not rhythm control, rate control. See here, beta blocker. Rate control, what are the drugs you will give in atrial fibrillation? I told you it is B, C and D. This patient is hemodynamically stable. Why? Because BP is 130. If BP is fallen, that is what is hemodynamically unstable. No. For hemodynamically stable patient, B, C and D. Now, this patient has, listen carefully, asthma. So, can you give beta blocker? No. So, beta blocker cannot be given because the patient has asthma. Amiodarone. This is for rhythm control. This is for rhythm control. You cannot give it for rate control. Now, coming to verapamil, it is a calcium channel blocker. But I told you, calcium channel blocker cannot be used in HFrEF because it will decrease the contraction. So, calcium channel blocker cannot be used. Verapamil is not the answer. What is left out? D for digoxin. That is why the answer is digoxin. Did you understand? So, this is how you have to rule out the questions. Let us suppose if the same question is given and the patient do not have any HFrEF or bronchial asthma. What is the answer? The answer is beta blocker. Let us suppose same patient is given and they told patient only has bronchial asthma, no HFrEF. What will be the answer? Answer will be calcium channel blocker. Let us suppose the same patient they asked you rhythm control. What will be the answer? Answer is amiodarone. Yes? Now, we will start with the next chapter. Okay.